My name is Marianne Oppås. I am a researcher at the Norwegian Center for Violence and Traumatic Stress Studies, Oslo, Norway, of course. My main research field is refugee trauma. I'm also a clinical psychologist and have worked as a therapist with traumatized refugees and other groups for many years. I will talk about reactions to severe trauma and what may be helpful for individuals exposed to the atrocities of war. The war in Ukraine that started on February 24th this year has caused extensive suffering and destruction. Additionally, the war that was going on in Crimea and eastern Ukraine since 2013 and 14 had already resulted in many deaths, large groups of internally displaced people, and psychosocial problems. Presently, there has been extensive damage in many regions to people's homes, public buildings, health facilities, and infrastructure. We have heard reports about atrocities committed by the Russian army to men, women, and children, with unprovoked killings of civilians, torture, and rape. People have been hiding in basements and other underground places with little access to water, food, and daylight. Families have been split up, and family members, friends, and neighbors have been killed or wounded. Presently, more than 6.3 million people have fled the country, and around 8 million people are internally displaced. Among Ukrainian refugees, many reside in nearby countries, and almost 3.5 million reside in Poland. People react differently in the face of danger. They freeze, cannot move or act. They fight and try to solve the situation, and they flee. These are instinctive reactions meant for survival, depending on the circumstances. In the aftermath of danger, people also react differently, depending on personal characteristics and characteristics of the stressful events. Some of the personal factors that may increase the risk of stronger or more prolonged psychological or psychosocial difficulties after trauma are female gender, very young age or old age, poverty and socioeconomic difficulties, previous or current psychological problems, family dysfunction, previous trauma exposure, and genetic dispositions. Characteristics of the stressful events that are related to stronger or more prolonged difficulties are such as intentional acts of violence rather than accidental or natural disasters, life threat, the extent of exposure to combat in war, being physically injured, witnessing death, loss of loved ones due to trauma, life-threatening illnesses, unpredictability and uncontrollability, and long duration or greater frequency of traumatic events. Cumulative adversities and trauma make people more vulnerable to developing mental health and psychosocial problems. The next threatening experience may just be one too much. In war and other mass conflict or individually committed violence, the fear and suffering is caused either directly or indirectly by other human beings' acts and decisions. Usually in war, the acts are intentional and willed. Examples of intentional acts of violence are armed attacks, torture, rape, and other sexual assaults, domestic violence, and child abuse. Research has shown that violence caused intentionally by other human beings bring about the most severe reactions in those affected. Many people handle adverse life events with resilience, without reactions that impede their functioning. Some are able to handle repeated experiences of adverse life events without getting sick. Some get strong reactions for a while, but then recuperate fully. Resilience refers to the individual's ability to use resources within themselves and in the environment to overcome distress. Even if the individual does not fully have these capacities, resilience can be stimulated by active outreach and support from others. Relationships are important in times of extreme stress. One friendly person can make a difference. In their book chapter, Everly and Leiting in 2019 refer 6 primary factors that may protect against and aid in recovery from extreme or traumatic stress. The first is actively facing fears and trying to solve problems. Next, regular physical exercise. Then optimism and following a moral compass. Promoting social support, nurturing friendships, and seeking role models. And lastly, being open-minded and flexible in the way one thinks about problems and avoiding rigid and dogmatic thinking. As helpers, we can promote people's resilience by helping trauma-affected individuals to see their own strengths, to see whatever choices there may be in the situation, by supporting their trust in themselves to be able to influence their environment, and by supporting their belief that they can tolerate and bear their own thoughts and emotions. Also by teaching them to talk supportively to themselves internally, and by encouraging them to seek companionship and support through relationships. As a helper, you can also strengthen traumatized people's sometimes frail belief in humanity by being kind and to be trusted. There are many feelings and reactions to trauma that are normal human responses to extreme or cumulative stress. Nevertheless, they are extremely unpleasant and often a cause of concern to the people experiencing them or to his or her family. It may help to know that these reactions are natural responses to having experienced severe threat. Many kinds of stress and adversities during one's life may contribute to the psychological reactions or health problems that are found in refugee populations. These include adverse and traumatic events during childhood and adolescence, highly threatening war and conflict-related experiences, human rights violations, and dangerous situations during flight, as well as psychosocial stress in the place where one finds refuge, whether internally in one's country or as a refugee in a foreign country. Reactions to trauma are often presented as emotional, physical, or cognitive. It is often difficult to distinguish between them. We are one organism, and what is happening to us affects our whole body and mind, our feelings, our ability to think, concentrate, and learn, our spiritual self, and relation to others. Emotional reactions include such as shock, disbelief, grief, anger, irritability, anxiety, fear, and insecurity. Trauma and stress over time also affect our physical health and well-being. After experiencing severely threatening situations, some physical reactions may be sleeplessness, nightmares, restlessness, jumpiness, high bodily activation, being on guard, or feeling weak or distant. Severe or long-lasting stress can cause physical disease. Many will experience problems concentrating, problems remembering things in daily life, problems learning new things, loss of creativity, or loss of interest in activities that were previously joyful. Some will feel rejected, forgotten, and let down by God, or may lose faith temporarily or in the long term. Others will turn to God and feel strengthened. Depending on age, personality, and the context, some individuals become more depending and clinging. Some become easily irritated or angry. Some become very quiet and keep difficult experiences and feelings to themselves because they don't want to burden their loved ones. And some isolate themselves to avoid trauma reminders or a feeling of social shortcomings. Some cannot bear to be physically intimate after severe experiences. Others seek relief through intimacy. Some do a mix of all of this. After traumatic experiences, family members may become more close to one another, or they may drift apart. There are some things you can advise a person to do when she or he seems to become anxious and overwhelmed. This is also what you as a helper can do if you feel things are getting to be too much. Stand on your feet or sit straight with your feet firmly on the ground. Look at objects around you or people, anything that looks normal. Breathe deeply and slowly, 3 seconds in, 3 seconds out. Move your limbs, your shoulders, and your body. Stretch your arms up and out to the sides. Maybe dance even if you don't feel like it. Be with someone you trust if possible. Go for walks if it is safe. Write down recurrent memories, thoughts, and dreams that bother you. Resume ordinary activities if you can. If you are a therapist or other helper that is offering short-time support to people who have suffered traumatic events, here are some things that may be helpful. If possible, offer a good chair, something to drink, maybe a blanket. Introduce yourself and what you know about the person or situation. Tune into the person with the tone of your voice, your facial expression, and bodily posture. Ask a few questions. Be there and listen, and give some feedback. Show empathy. Little comments like, "That must have been very scary," or "I'm so sorry for your loss." Be reassuring but honest. Now you are here, you survived, now you are safe. Do not worry if the person starts to cry. You have done nothing wrong. Be supportive. Do not worry if you get some emotional reactions yourself, like tears in your eyes. It is okay if the person you are helping sees that what they have suffered makes you feel angry or sad. However, stay calm, calmer than the person you want to help. Give relevant information about normal reactions, how to handle stress, and where practical help may be obtained. Accept your own feelings of helplessness. What you do is helpful, even though you may feel you have nothing to offer. After helping others, do something good for yourself. In most people, the reactions that I just mentioned may be strong in the beginning, and then they slowly diminish. In most cases, low-threshold psychosocial support is sufficient. But there are some warning signals to be aware of, signs that professional evaluation, treatment, or other measures may be acutely required. In cases if a person shows apathy, stays in bed, resists food and drink, does not respond to anyone who is trying to make contact. By suicidal ideation or attempts, by rage and threatening behavior, severe substance abuse, violent acting out or being a victim to violence in the present, extreme confusion, possibly dementia, by pointless and hectic behavior, and by psychotic symptoms, delusions and hallucinations. Sometimes the whole personality changes from how he or she used to be before the traumatic events. The person may develop a chronic feeling of being on guard, of imminent and lurking threats, distrust towards other people, social withdrawal, feelings of emptiness and hopelessness, feeling alienated from other people and the world around. Some personality changes may pass within some weeks or a few months. However, sometimes these changes take hold. Major happy life events and a loving and safe relationship may counteract such distrust, alienation, and feelings of threat. But sometimes psychotherapy over time is the only remedy. Exposure to severe trauma may not necessarily lead to symptoms of post-traumatic stress disorder, PTSD. When people experience excessive stress, they do react in different ways. Other than PTSD, people may develop depression, anxiety, complex post-traumatic stress disorder, that is with some of these personality changes I mentioned, somatic complaints, pain problems or physical disorders, substance abuse, personality changes, dissociative disorders, or psychosis. More often than not, people develop problems in more than one area, such as comorbid PTSD, depression, and somatic problems. For those of you who are in the position to provide psychotherapy over some time to someone who is affected by traumatic experiences, here is a list of what I have found helpful. Be kind, caring, and accepting. Listen, but also share empathic reactions to what the patient tells you and give feedback. Address here and now worries. Instill hope. Check sleep problems and nightmares. Attend to bodily pains. Ask if bodily symptoms and pains are more intense at times, and at what times or in what circumstances. Also note if there may be a need for a medical check. Map the individual's personal strengths, skills, and resources. Assess and attend to what is bothering the person the most at the present, be it worries of loved ones, psychosocial problems, depression, anxiety, or post-traumatic stress symptoms. To work therapeutically with trauma, choose incidents that invade thoughts or appear in nightmares, and that presently bother the person the most. To address trauma, you may use whatever method you are comfortable with or that you feel works with the particular patient. Eye movement desensitization and reprocessing, trauma-focused cognitive behavioral therapy, narrative exposure therapy, or just talk therapeutically with the person about the experience, gradually in more detail. For a start, nightmares may be somewhat easier to talk about and work therapeutically with than what actually happened. Working with one traumatic incident may also be helpful for other incidents that are not dealt with in therapy. In my experience, writing down what they tell you and then reading it out loud to them later in the session or on the next meeting can be a strongly emotional and painful, but also a deeply confirming and healing experience. Trauma may disturb an individual's perception and interpretation of events in daily life. If this seems to be a problem, support the person's reality testing and understanding of encounters with other people, events, and aspects of the society. This can be done by discussing current and troublesome experiences and relationships. You can also encourage patients to express their beliefs and impressions of you, the therapist. Confirm if their perception of you is correct. Confirm and disconfirm only those things you are absolutely certain about. Keep an open mind about experiences that cannot be easily confirmed or disconfirmed, but discuss different alternative understandings. Accept crying and other strong reactions. Stay calm and reassuring. I'm going to tell a little bit about a longitudinal project that I have been working with the last 16 years. It may not be of interest to all of you, but I will tell a little. In a longitudinal study at our center of psychotherapy patients with refugee and trauma background, we found that many of the patients had suffered various childhood adversities in addition to war-related trauma, persecution, torture, or sexual assaults. The amount of war-related trauma that individuals had suffered, mostly as an adult, was significantly related to post-traumatic stress symptoms, especially re-experiencing symptoms. But childhood trauma was related to arousal symptoms of post-traumatic stress and of poorer quality of life, especially more problems with relationships. Patients with childhood trauma, in addition to war-related trauma, had more symptoms of mental health disorder and lower quality of life at treatment start than those without childhood trauma. A trauma-focused personality assessment showed that the patients were characterized by varying or oscillating levels of flooding and constriction, and by varying levels of trauma-related problems with reality testing. Flooding means overwhelming and intrusive thoughts and feelings, while constriction means traumatic avoidance and inhibition of thoughts and feelings. Difficulties with reality testing was usually not a sign of pending psychosis. Breaches in reality testing may appear when under the influence of traumatic reminders. Because of traumatic experiences in the past, some may misinterpret events, situations, and other people's motives and acts in the present. In our study, we found that those whose reality testing and judgment of the present functioned well despite traumatic reminders improved more rapidly in therapy. For those who have more problems with perceiving more objectively what is happening when under the influence of traumatic reminders, a longer therapy or a therapy more focused on discussing present relationships and experiences may be required. We followed up the former patients from 3 to 10 years. At group level, we found that they improved significantly over the first years. However, men did not respond to psychotherapy as much as women, and those with a higher number of trauma, those with experiences of torture, and those with childhood experiences of violence within the family had a harder time recovering from their mental health disorders than those with less trauma. Of note is that these therapies were mostly conducted sometime between 2006 and 2012. Many of the patients had been more than 10 years in Norway when they entered treatment, and their problems may have become rather chronic. Besides, this was a small clinical group of former refugees with mental health disorders and not representative for all individuals exposed to war and trauma. The participants were 54 patients from 15 different countries around the world. The largest group was from Middle Eastern countries. It was a naturalistic study where the patients received therapies of different theoretical orientations and of different lengths. There are not many studies reported with such long follow-up, but comparable studies with participants from other parts of the world, with treatments from a time period closer to the present, or who received more specialized trauma treatment, may have yielded other results. At the present, when the Western world is more aware of mental health issues, and we seek to give low-threshold support to people who have suffered traumatic events, more people may be helped so that they do not become chronically ill or unable to function. We believe the following is helpful to strengthen resilience and health. For the trauma-affected individual, it is important with basic safety, access to shelter, food and water, of course. But also to be met with respect, accept, solidarity and human kindness. And to be able to stay active and use one's resources, not be left to long-term passivity in reception centers. To have or be given some basic knowledge of normal reactions to trauma and what one can do to alleviate stress and help oneself or others. For the communities, it is important to allocate resources to those with acute need for physical or mental health treatment or other psychosocial measures. For the communities, it's also important to have a long-term perspective of preparedness to meet mental health needs, as some needs may arise during ongoing danger. Some needs may arise shortly after individual safety is restored, while in some people, mental health problems and needs in the aftermath of trauma may only arise or be recognized after months or even years. Here you can find some references and background sources for my talk. And here are some resources where you can find useful strategies for support. This is all I wanted to say today. Thank you for listening.